Most of my research has actually been in relationship marketing, so it was a very natural transition. And healthcare is just a intrinsically rewarding domain. And in terms of relationships in healthcare, last couple of years, my mom got, a couple of years ago, she got a very serious diagnosis back in Russia. So I've been dealing with a lot of doctors, and it just hit home that how much the relationships matter to patient outcomes. But before we start talking about relationships, I think Poonam and I were thinking along the same lines. So we really have to look at the healthcare ecosystem as a whole, because it is very complex. It doesn't really function as do other industries and free market in general. So at the center is obviously the relationship between the provider and the patient. But all these other parties that you see, like payers, regulators, have an impact on this central relationship. And there are underlying trends that are happening right now, at least in the consolidation, that are also going to impact this central relationship. So I just wanted to highlight a couple of different domains where I think relationships between the provider and the patient can really make a difference. The first one is non-compliance. It's a big problem, widespread, obviously affects patient outcomes, but it's also a big problem that pharma is trying to solve. And I think this is one place where relationships can really help reduce it. Another domain is to see how relationships can help enable the shift from a disease-oriented culture that we have today, where doctors, physicians are focused on managing symptoms, rather than a health-oriented culture like they have, for example, in Japan, where they focus on preventative care. They spend a lot less money per patient. Their health outcomes are a lot better than here. So how can relationships between providers and patients help us move in that direction? I think Poonam already mentioned the role of technology, so I'm going to skip that for the sake of time. And then the last 2 points are also big domains where I think relationships can help, which are physician turnover and physician prescribing decisions. And I'm actually going to talk about those two on the next slide. Okay. So these are just a couple of projects I've been working on, and these are just preliminary findings. This first one is on strategies to mitigate this big problem in healthcare, which is turnover. It's a widespread problem. It's very costly. It can take up to $1 million to replace a physician, and that's not accounting for loss of revenue costs. Obviously has negative impacts on patient, on their continuity of care, has negative impacts on organization. And what is interesting about healthcare is that a lot of the strategies that work to mitigate turnover in other industries don't really work in healthcare. So given that this is the set of the kind of variables that we have to deal with, what can we do? We worked with a healthcare organization, a very large one, and we did qualitative interviews with everybody from very top levels to receptionists. And then we also did a survey of their patients matched with their healthcare data, and also data that would let us know if the patient has experienced a turnover. And just a couple of insights, I'll just highlight the most interesting ones, is we found that when we looked at the different departments in this healthcare organization, we looked at maybe like 40 plus departments, there was a big variance in how they went about their staffing decisions. So in some departments, patients would see their doctor, but they would also see the same nurse, same medical assistant. And in other departments, it was more ad hoc. So what we saw is, if the if the turnover happened in the department where the rest of the team stayed the same, it helped to mitigate the effects of turnover. And we also saw that, we assumed that this relationship between the physician and the patient is what is most important to the patient. But we saw that some patients actually value their relationship with a medical assistant or a nurse more than they do their relationship with a physician. So that's something that's worth paying attention to. And then just very briefly, another problem, or I guess big domain where we look at how relationships can help, is off-label prescribing, which is, I'm not sure if you're familiar with it, but in the US and other countries, once a drug has been approved by, let's say, an FDA to treat some condition, the doctor can prescribe it to treat any condition that they see fit. Most of the time, the patient isn't aware that the drug has been prescribed off-label. So obviously that makes it more risky for the patient because the drug hasn't been tested for that condition. So we'll look at, in a CoinJoint study with the actual objective prescription data, Irina and I, who's going to speak in a bit, we looked at, how do physicians make a decision between prescribing a drug that's been approved for this condition versus an off-label drug. And we find factors like some sort of similarity between physician and patient, like physician has also experienced maybe this issue, or they're of the same gender, makes them prescribe the off-label drug more. Just one last point. In our study, we had the approved drug was actually very expensive and off-label drug was very cheap. And we found that our preliminary findings that higher price of the approved drug actually diminished the use of the much cheaper off-label drug. So that was interesting. Thank you so much.